Women make up 70% of the healthcare workforce, but only 20% of its leadership. On Her Story, we'll explore the careers of bold and influential women from Silicon Valley to Capitol Hill and learn how they've overcome the odds. I'm your host, Angela Jane, and this is Her Story, a program where we explore what's beyond the glass ceiling. This morning, I'm delighted to welcome Peggy O'Kane, founder and president of NCQA. Peggy, thanks for being with us.
Happy to be here, Angela. Nice to meet you.
So you've really been a pioneer in the healthcare quality space. Tell us a little bit about the mission of NCQA and who you serve.
Our mission is to improve the quality of healthcare. And how I got here is kind of an interesting story. Would you like me to start with that?
Sure.
So I was a French major in college, and I taught second grade, and I was trying to find my career. And I became a respiratory therapist. And I worked in hospitals for 5 years, and the quality issues were so evident that I would just come home with my hair on fire, and my husband would say, "You should go do something about the quality of healthcare." And at the time, there really was no good way of thinking about quality. There was a lot of peer review, which was kind of doctors reading each other's charts, and usually when something bad had happened. So there really was no way of kind of engineering quality into the system. And so I went to graduate school. I learned what I could learn about quality. It was at a time when corporate America had embraced quality. Continuous quality improvement was a big deal. Lots of corporate people had black belts in quality and so forth. So it was a convergence of things and a time when corporate America understood that the quality of healthcare wasn't what they wanted it to be, and we're looking for a way to drive it towards better quality.
Wow. So a lot to unpack there. So I guess first, I think quality is a construct that we all have different definitions for. How do you actually define it?
Did the right thing happen to the person at the right time and in the right place is a nice way of thinking about it. A fancier way of thinking about it is, from what we know from medical science, was the right thing done? That's a little more elaborate. And done in the right way.
You started off on more of a clinical track. Mm-hmm. So what originally inspired the decision to go train to be a respiratory therapist? Where did the healthcare kind of interest even
Well,
stem
to be
from?
honest, I was looking for an easy way to get into healthcare without going back to school. It was at a time when respiratory therapists were trained on the job. It was a new field because ventilators were just starting to be in wide use. And so I went in, I trained on the job. I picked up a degree in respiratory therapy along the way. But it was an easy way to get into healthcare. And, to be honest, it got boring after a while. But it was an incredible learning experience with just kind of powers of observation. And also there was this emotional part of it that I think motivates me about quality. You see patients suffering unnecessarily, and the quality of care not being what it should be and what the consequences are, it's really motivating. And I draw in that kind of, those kinds of stories of what happens when it isn't good to motivate myself all the time.
And did you grow up around healthcare? Was that an influence in your family?
No, I was the first college graduate in my family. I was born in Germany. My mother was a German. My father was in the Army. And I grew up in Brooklyn, New York. And, I was, as I said, the first college graduate. There was nobody professional in my family on either side.
So trained as a respiratory therapist, you saw the disparities in quality. You decided to then go get your graduate degree, another one, I guess, at Hopkins, correct?
Yes, correct.
And at Hopkins, what was the thinking there? Was it health policy and management?
Yes, it was health policy and management.
Okay.
Yes.
And so was it straight out of grad school then? So where did the idea of NCQA then come from?
I started with an internship with the federal government and worked for the Health Services Administration, which is now part of HRSA. And I worked with community health centers and maternal and child health programs and so forth. It was an office of evaluation. And it was really interesting and really, this kind of population health really was the theme. And I was caught by that. And community health centers were way ahead of their time in terms of population health, a whole person focus. They were really pioneers, I think. And so I took in all that, became part of my value system. And then I worked for a research group at George Washington University and learned a lot about states. It was a state research group. And, I kind of was still carrying this quality agenda inside me, but there weren't good jobs in quality. There were these things called professional services review organizations. It was just,
Right.
nothing particularly good. Paul Elwood at the time was a big thought leader in healthcare, and he was very much advocating for health maintenance organizations. And I actually had been a member of a health maintenance organization at a time when I lived in Boston. It was one of the first in the country, the Harvard Community Health Plan. And I always thought the idea was fantastic. And Elwood was an evangelist for this idea, and he recruited employers and even insurance companies towards this idea. And so the idea of the accountable health plan was starting to shape itself in the employer community. And so I was working then at the HMO Trade Association, and we were trying to figure out our quality agenda. And so I had all these ideas from graduate school about how to measure quality and how to think about it. But I needed I needed a way to make it happen. And so we found the employers. They said, it doesn't make sense for us to be running around with our own consultants, everybody asking different questions, everybody asking people to measure quality in different ways. And so NCQA came together as a kind of convergence of, I think, plans that wanted to demonstrate their good quality and employers who understood what that meant.
I think what's interesting, so we talked about this, I have a health services background,
Yeah.
and population health and quality. A lot of these terms we're still talking about.
Mm-hmm.
And when you were thinking about it, this was before the popular, Institute of Medicine to Era's Human Report. This
Yes,
was kind of the early stage of the Clinton Health era. What was the actual conversation like in the healthcare industry around quality? Was it actually something that folks were talking about?
Yes, because of the employers, because the employers were on this. First of all, as I said, many of them were trained black belts or, whatever belts they had. So they knew how to think about quality. And I just remember the chief human resources officer at Xerox said to me, I go visit our plans and I say, so tell me, how do you do with taking care of people with diabetes? And the plans would say, oh, we're fantastic. And she would say, how many people with diabetes are in your plan? And they would say, gee, we don't really know. I think the employers, through their training, understood that this was it was a numbers game, and it was a measurement game, and it was a kind of, if you don't measure, you don't know where you are, and you don't know when things have gotten better. But this was still kind of a new concept in healthcare at the time.
You formed NCQA with what specific mission at the time then?
To improve the quality of healthcare. Our mission statement was to improve the quality of healthcare, but in fact, what we were doing was accrediting HMOs and measuring the quality of care that they gave. So these were in two separate tracks. And the employers kind of helped us design the accreditation program, helped us figure out what to measure, and then mandated it. And so we went from an idea to a reality in a very short time.
And how does the organization actually work with other stakeholders across the industry? So you've got the employers, there's also the government.
Yeah, we have a multi-stakeholder board. So we have a consumer member. We always have a consumer member. We have quality experts. We have, people that have been consultants. We have health plans, very small number of health plans actually on our board. We have a hospital CEO on our board. So it's kind of multi-stakeholder. The kind of, you need like finance and strategic expertise on your board. So we have people with that. And so we have a fabulous board.
Well, I think bringing together all those stakeholders is really quite important because as we've talked about before, healthcare is so siloed. And so I think it's really unique that you sit at this intersection of bringing all these groups together. How do you think about the concept of the fact that why did you form a nonprofit as the organizational structure?
It wasn't even a question at the time because the idea of being a for-profit doing quality, I don't think people would have trusted us. Now, I think today it's a different story, and there are plenty of for-profits doing great stuff in quality. And I think there are advantages to being able to raise capital and so forth. But I think we will continue to be a nonprofit because we serve the public interest. And I think people, they're looking for hidden agendas everywhere anyway. There's a level of trust problem. So we just keep that one off the table.
And how are you working? So you kind of fast forward, the evolution of the quality discussion in the industry. From your vantage point, are we making progress? What are some of the roadblocks that you're seeing?
I think we're making progress in some sectors. So where we have clarity about accountable entities, and I think value-based payment is part of it, where there's an enterprise that has goals, that's trying to do a good job, and they have the measures to prove it beyond what we measure, and trying to work within a budget, then I think you have what's really necessary to get to good quality. I mean, we tend to think of quality in healthcare, and I think it's because of our fee-for-service system as a trade-off. Like you can pay more or you can have good quality, but you can't have both. And I think that's so wrong. And so much that's wrong with quality in healthcare is because of the crazy incentives.
How do you, healthcare is just so political. And so what's interesting is that you all have worked with both sides of the aisle, different administrations. Yeah. How does that influence what NCQA is able to achieve as you're bringing stakeholders together?
There are differences, and I think the most important difference is in the concept of universal healthcare coverage, which I do support. And I do think a lot of mischief comes about because people are trying to figure out how to offload the high-risk patients, which creates a lot of, very bad dynamics. So, but other than that, everybody's sweating about the cost of healthcare, right? All the states, it's their biggest spending item. And, like we've just been through a period when a lot more people showed up on Medicaid and so forth. So Medicare and Medicaid, they're on the hook for this money, and they're also scrutinized by the public about what kind of a job they do with the public dollar. So they are heavy drivers of our work. And the employers, the employer scene is quite different than it used to be. The employer is at risk, not the health plan. So that creates also some funky incentives, I think.
Right. There's a little bit of a debate over the importance or effectiveness of measurement and metrics, right? Yeah. And so the academic in me thinks a lot about Donabedian's model and structure process outcomes. You've got a lot of the business gurus that talk about if you can't measure it, you can't manage it. Mm-hmm. How do you view kind of the balance of actually having the right measures? I mean, are we keeping up to pace with, as we think about digital and telemedicine?
Well, yeah, that's a whole thing.
Right.
That's
how do you just think about that?
That's our preoccupation right now So we spent a lot of money on the HITECH Act to get electronic health records. We have data all over the place, and it's not serving us. And, the practitioner that's trying to do a good job often doesn't have the information they need, even though they have this very expensive, very sophisticated medical record, right? It's really, it's a shame, we need to do better. So we envision a digital future when practitioners actually are given the information they need to do the right thing the first time, and where everybody can succeed at quality. We're not trying to, separate the evil from the, practitioners are trying to do a good job, and organizations are trying to do a good job. And it is often the lack of information at the point of care, or the lack of sophistication about how to engineer their processes. So those are our ultimate goals, is to get everybody to a level of performance that's terrific, and where we get the return on the investment that we put into healthcare.
So as you think about the last 20, 30 years in the industry, from where you started looking at quality on the employer side, then you had the HITECH Act, as you mentioned. Mm-hmm. Now we have CMMI and value-based payments that are kind of further incentivizing us to think about metrics and reporting. Are those kind of initiatives or policy levers kind of critical to accelerating this momentum, or what do you see as kind of the next decade look like in terms of kind of solving the data issues and actually
well, we're hopeful because there are a lot of people working on this, and CMS itself and the states, the Medicaid programs are on this. They're very aware of how the system falls short, and they understand it, and they're trying to drive change. So CMS has said quality measures are going to have to be reported digitally by 2025, which is very ambitious. But, there's a lot of progress being made in a lot of systems, but it's very uneven throughout the country. And, particularly in classic Medicare. People have supplemental insurance. That data is separate from the Medicare claims data. There's no accountability. It's kind of a mess. Medicare Advantage has been kind of a bright light of the right model, in my view. But during COVID, they backed off on a lot of clinical quality measures, so they're much more less heavily weighted now in the stars. So we have a lot of work to do.
So as you think about the evolution of NCQA, kind of tracking with the evolution of the industry, how have your priorities specifically as the leader of the entity, kind of changed to match those?
I always use the metaphor of being in a car on a foggy night, and you really can't get out in front of your headlights. You have to you're learning. It's one of the reasons I've been in my job so long, is it's so energizing and fascinating. It's such a problem to be solved. So we started off measuring very simple things like preventive services, because there was a very well-regarded preventive services task force that said, here's who should get what, and very, very specifically. So we were able to start with that. We moved on to chronic conditions, and we're very proud of the work we've done. It really has it's resulted in lives saved and better quality of life for people. But then it's always, I'm kind of a glass half empty kind of person, so you think about people who are in their 80s, and the science is not really very well done for people in their 80s. So the way the scientific enterprise of healthcare works is we do clinical trials. They tend to be by organ system. Even if you look at how NIH is organized, it's by organ system, right? We test the drugs and the treatments on younger people without other conditions, and then we go out and apply this knowledge to people that are in their 80s or who have multiple chronic conditions, and it doesn't work so well. So we're working now on some stuff that's really interesting about we call it patient-driven outcomes. It's funded by the SCAN and Hartford Foundations. And basically the concept is, and we've started with elders, but I think the concept works really well for other kinds of patients as well. What are your goals? What would you like to have as your goal if your health allowed it? So, what elders tend to tell us is things like, I'd like to go back to church, or I'd like to be able to walk around the block, or I'd like to go visit my children, get on a plane. And so you can align that goal with kind of things that they can do to be more healthy, like a little more exercise perhaps, or something like that.
You're really alluding to the power of data, right?
Yes.
So data to underlie better decision-making, better practices. Mm-hmm. But as an industry, we've really struggled with that. We're kind of circling around it. We're working with data. It may not be as usable, but how do you view kind of the connection between using evidence to actually inform decision-making or strategies kind of at the systems level? And what does it take to kind of get our industry comfortable with that kind of thinking?
Right. So let me go back to Donabedian, because I think Donabedian remains to me a beacon. Yes. And his idea of, 3 ways to think about quality: structure, are things organized right? Process, how are they doing what they think they're doing? And the last one is the outcome. I think, and we've kind of led the charge on measurement, right? People see measures and it just feels more real to them than structure and process. And so there's this great outcry that we need the outcomes, and we don't need to know about whether they're organized appropriately or whether they're doing the right thing appropriately. I think that's a mistake. From your background, that if things aren't organized right, you can't even measure how well you're doing, right?
Exactly.
I think it's a kind of more of a nuanced weaving together of structure, process, and outcomes that's necessary. So we've been doing work on depression, and so it's kind of like you have people organized to do the PHQ-9 as a screener, and then identify people with depression, then follow up with the people after, put them on meds, do whatever it is, to treat them, put them in therapy, and then follow up and see what the remission rate. And this is built on really pioneering work done by Jürgen Unitzer, who's at the University of Washington, so I want to call him out. But so what you do then is you track the patient and you make sure that it's working. And, luckily depression is treatable and people can really do better. But if you're not looking, the remission rates are really low. He doubled remission rates in his scientific work. And so we're taking that kind of a notion. And you can apply that to other things as well. You can take people who are obese. This is one of the knottier problems, right? And work with them. And, so I think that the potential of using the outcome as the ultimate metric, but really holding people accountable for, did you do the right thing? Did you follow up? Did you kind of, if the intervention wasn't working, did you try something new? So I think that's really the way to think about it.
It's music to my ears. So as you know, I spend a lot of my time really on the structure and process side. And so the conversations that I'm having a lot with organizations is, how do you measure your strategy, or how do you kind of capture that only so that you're accountable, so that you can actually see which levers are influencing those outcomes and trying to get us to move a little bit more upstream. But it's like we talk about data and we talk about measurement, but I think we all kind of define it a little bit differently.
That's right.
You've been relentlessly focused on this, probably longer than most in the industry, right?
Yeah.
A lot of people are looking at it from very niche angles, and they're all really important, but you really have this systems view to it.
I do. I'm lucky.
But take us back to the origin story a little bit. I mean, you founded this at a time when, yes, people were talking about it as you mentioned it, but not really kind of intentionally focused on it in the way that you were, where you said, we're going to actually form an organization that's just focused on this. You also did it at a time when, we know that there aren't many female founders in the industry. Even today we're not, but when you started, even less. So just tell us a little bit about that experience. Do people think you were, kind of chasing after something crazy?
It was a sneak attack because, people underestimated me, partly because I was a woman. I mean, I wasn't a doctor, so... but what I understood was that I needed other people to help. And I've always had good luck hiring great people and having a wonderful board of directors, wonderful committees. I mean, we just have the greatest brain power. We had our standards committee yesterday, and it's in 2 days. And just you just sit in awe. And that's how it worked. So what you have to be able to do is kind of get people to want to help you, and then take their best ideas and implement them. So, I feel humbled by the work, because it is so complicated, but I also feel so empowered by the goodwill of the people that work with us, and like the people that run quality all over the healthcare system. You can't find a more dedicated group of people, honestly.
Yeah, I think the passion really shows there. I think something you said that's really interesting is, back at that time, really we would say that the physicians were kind of our customer, right? That's kind of how we operated the system. And now it's really our patient and the consumer is the customer. And so...
At least the rhetoric says.
Fair. We'll have to... That would be an hour-long conversation just on that. But when you were starting, to your point, you weren't you were a clinician, but you weren't a physician.
Right.
How did you navigate that dynamic where really you were in the business of trying to kind of tell physicians, how to...
Me, even today, I get hate mail. I get, lots of rude tweets and so on. The thing is, quality is not only about the medical science. It's really about the art of delivering care in a consistent way. So a lot of it is not rocket science. Some of it is. But, the part that isn't rocket science is the part where we neglect it.
And so zooming out, if you think about the advice that you would give, to other women today who are, trying to create something, build from scratch, I mean, how do you kind of push through that noise when people are telling you that, it might be a crazy idea or you don't know what you're talking about?
You have to have a thick skin. So you have to kind of be willing to have people look right through you. I mean, we all know about, the kind of implicit bias that we deal with. And it's just... You've got to believe in yourself, and you also have to have the humility to, when somebody calls you out for something that you're not doing right, to take it in and really reflect and maybe do something different. I mean, that's one of the things that's really, really important. In a field this complicated, you're gonna make mistakes. And so you've just got to be open to that.
If you were to restart, build NCQA from the ground up today, in today's era with, the iPhone and the High Tech Act,
I don't know.
what would you do differently?
I don't know that what I would do differently. I feel like the employers were so foundational to getting us launched, and I don't think it would be possible today because the employers are kind of all over the place, and there doesn't feel like a really strong strategy as there was when we were coming up. So that convergence of things, I guess, I would be working as we are very closely with CMS, very closely with Medicaid. So I feel like what we're doing now is kind of how we got here by just kind of responding to the environment and also keeping our core beliefs front and center. So that's kind of the what you have to keep doing. I mean, yeah, I would start with digital today because it's where the action has to be. And we're spending so much money on data and we're not it's not even there for the most basic of uses. It's pathetic. So but again, that's where we're putting, I think, a high proportion of our intention right now.
One of the things that the data is showing very clearly, and I think COVID really exposed this, is the disparities that we have in quality
Yes.
and treatment and everything for certain populations. How are you thinking about health equity?
We're very proud of the work we've been doing. The thing is, I think people used to think, well, there's quality and then there's health equity. And I think what this has shown us is that they're really not to be separated, that health equity is the path forward on quality, that if you close those gaps, you're going to have the biggest impact on quality. And so one of the things that we've been doing is kind of talking to other quality organizations like the National Quality Forum about, can we all get on the same page about measurement? And we want to stratify our HEDIS measures, right? So by race, and we want to see what the actual gaps are. We've been helped a lot by states that have been on this for a number of years. I would particularly mention Pennsylvania. Dr. David Kelly sits on our performance measurement committee. They have just pioneered this, and they have managed care plans, and they've got them working on. We have a program called multicultural health care, and then they're measuring the impact, and they're seeing the impact. They've closed the gap. It's not 100% closed, but it's an incremental gain, quality improvement. So it's what we're doing is trying to get the quality enterprise to kind of point in the same direction. We tend to have everybody running off in different directions, and it sends very unclear signals to the delivery system.
The incrementalism point is really important, right? Because to your point, I mean, we move so slowly in this industry, and some of it is inevitable, and each thing kind of it's a foundation for us to build on.
Yeah.
So as you think about the next decade, kind of the post-pandemic health economy, if you will, as it relates to health equity and measurement and quality, are there things that we can do as an industry to accelerate some of this?
Yeah, I mean, it's kind of gets serious about engineering clinical process. I think for the government, the challenge is to kind of get clarity about who's accountable and then persist in holding them accountable. Reward them if they do well, fire them if they do badly, or encourage them to do better. And I think CMS has been, I think in the last 20 years, has been one of the more important forces, and Medicaid. As you know, Tom Betlak is on my board from Arizona, an amazing Medicaid program that he ran for years and relentlessly focused on quality and value. And that's what we need.
Well, I think a lot of that is the testament to what you've kind of galvanized as an industry. I mean, you really have been championing and kind of educating the industry along the way, and I think that's a big testament to your work. So thank you for all that you do.
Thank you so much.
So shifting gears a little bit then to you make it sound so easy, right? You've been at this, and it's been hard, thick skin, all important attributes. But tell us a little bit about kind of your journey actually going through each of these steps. So what support did you have along the way? Did you have mentors that guided you along this journey?
I did. Let me call out Gail, Warden, who you've probably heard of. He was the head of, when I met him, Group Health Cooperative of Puget Sound in Washington State. He became the head of the Henry Ford Health System. He's been a mentor to so many women that I know, just a selfless advisor. He was the chair of our board when we were starting up. So, but board members along the way, just fabulous people. Pat Naismith, the person I mentioned from Xerox, Helen Darling was also at Xerox and then was a benefits consultant. So I can't name all the people, but I'm just calling out a few of the people that encouraged me, mentored me, told me when I was screwing up.
Is there a difficult piece of feedback or advice that you've received over the years, whether it's from a mentor or someone else that you've been working with, that really has shifted your perspective at some point along the way?
I don't know if it's difficult. It's not my nature to be appreciative of the good things. It's, as I said, I'm a glass half empty kind of person. But to kind of really experience the sense of accomplishment and joy that comes when you make some progress. I think you need that in order to keep going.
And I know that you have 2 kids as well. So
I do, daughters.
You also, so mother on top of, running a really large organization. How do you think about, trade-offs, professional and personal, that you've, potentially had to make along the way?
Yeah, it was hard. It was hard, and I was divorced. So it was, very, very challenging. I felt guilty a lot. They tell me now that they were very proud of me, and when we had dinner at 9:00 at night, they were okay with that. But you have to let go of the idea of perfection in all that you do, if you're doing a lot, and who isn't doing a lot? Every woman that has a family is constantly having to navigate that.
Absolutely. And I think this idea of like the ideal way to do it is,
that doesn't
none. Exist, right? Yes.
Yeah.
So, I think what is a really fun fact about you is, you're so focused on measurement and precision, but one of your hobbies, I take it, is around kind of meditation, and I'll let you talk about that in a minute.
I wouldn't call it a hobby.
Not a hobby, okay. But it's an area that you invest a lot of time in, but that is something, from my perspective, is more intangible and something that you can't really measure kind of the impact that it has. But tell us a little bit kind of that outlet for you.
I teach meditation, actually, very like once a week, mostly once a month for something else. It's a great way to ground yourself and, to be real about like our human imperfections, and to realize that when you calm yourself, you're acting from your best self. So it's a kindness to yourself, and it's a kindness to other people around you, which I don't always succeed, but when I've been doing my steady practice of meditation, I'm at my best.
How did you get into meditation?
I was going through some personal. When I got divorced, it was a hard time for me, and I started. I picked up a book, and then I started going to to sits and stuff and retreats. Yeah, so I've been at it for a very long time. It's made a huge difference in my life.
I think one of the things that all leaders would probably agree with you on is that leadership is an ongoing learning process,
yes.
And so you're constantly teaching yourselves different things and reading. As you think about both personally or professionally, especially in the quality space, do you rely on outside industry perspectives? Thinking about quality in the airline industry or other what types of sources of information do you draw upon?
Oh, I mean, the level of customer service that you see in some of the outside. I mean, I don't know if I want to call out Amazon. The level of customer service is truly remarkable. And I'm trying to think of who else is an example. The airlines not so much. Ritz-Carlton. I mean, there are a lot of people from Ritz-Carlton have worked in healthcare and tried to imbue the system with that kind of dedication to the customer, with, I think, mixed results. Healthcare is so complicated, and I think often it's been built around the I don't want to say it in a judgmental way, convenience of the people that work in the system. But it's actually not even that, because it's it's too complicated, and it's hard on the people that work in it. And sometimes I think there's just a sense of, they have to preserve themselves in order to do their job. So and especially when we look at what they've been through in the last year with COVID, we have failed our healthcare system, our workers in healthcare, all of them, from the doctors down to the lowest worker. So there's just so much that needs to be done.
And as you think about, kind of your personal agenda then, kind of to go tackle these big feats, I think one of the things that is both a testament to your commitment, but also really rare in the industry is you have a founder of an organization that is very active in the day-to-day operations for as long as you have been. How do you think about kind of the team that you're building around you to kind of prepare the organization?
I have a very sophisticated group around me who are better at what they do than I would ever have been. So believe me, it's been a humbling experience to start out and not know how to do, pretty much anything. The good thing about growing is you can bring in people that are really great Absolutely. At what they do. And I have a team like that, so they're wonderful.
I guess as we kind of close then, what advice would you give your younger self?
Humility doesn't mean that you're less than. I think that's part of it. It's kind of like be willing to listen to people. Don't expect to be perfect. It really limits you. If you expect to be perfect and if you only have to be perfect, then you can't take in opportunities to do better and to grow or to supplement whatever it is you bring to the table. So it's kind of like about clarity and honesty.
You've already kind of roadmapped this, but I think it's interesting. So your entrance into actually healthcare leadership, you've had a couple of stints along the way, and as you know, we like to ask all of our guests, do you consider your kind of entry into the leadership realm more accidental or intentional? Curious how you would describe your journey.
Well, it's become more and more intentional over the years. It felt like an accident in the beginning. There were a lot of lucky breaks, but there was this kind of intentionality about doing something about quality that was there from the beginning. But I've become more intentional about kind of like the details, I think.
So then as you think about the, incredible legacy that you already have established for yourself, but will continue to chart forward, and one day we're going to write the autobiography for Peggy, what would be the title of your book?
I'm thinking of Elizabeth Warren's book, Persist. It is actually a lot of that, it's kind of believe in yourself. I'm sure there's a book called Believe in Yourself, but believe in yourself and work with others. Not a very memorable title, but that's kind of the theme.
Yeah,
that's the theme.
I think that really reflects a lot of your journey and the perspective that you bring. And I just want to thank you for all the work that you and your organization really have done in the industry as being one of the first movers in this space. And we're excited to see what else and you all have to bring forward in the industry.
Thank you, Sangela. It's really been a pleasure to talk to you.